Hey, empowered nurses, it's Lorie Brown, and welcome to COVID-19 Survival Guide for Nurses and Healthcare Practitioners. And today I'm extremely honored and grateful to have our special guest, Dr. Alexander Stemmer. Welcome.
Thank you.
So Dr. Stemmer is an infectious disease doctor, and I specifically wanted to bring him to the call because to share the latest updates on everything for you and how you can protect yourself as well. But first, let me tell you that Dr. Stemmer loves racing vintage sports cars since age 17, and how he's going to talk about how racing vintage sports cars and how he got interested in infectious disease. He's also a loving husband and father for 6 kids. So welcome, Dr. Stemmer.
Thank you.
So how did you get interested in racing vintage sports cars?
It is completely ununderstandable, since I grew up in an Orthodox Jewish home where we had not a single tool and nothing to work on. But magically, somewhere around the age of 12, I got interested in cars, went to the public library, took out every book they had on auto repair. And the first one I read, I couldn't get past the second chapter, but by the time I got to the third and fourth and fifth one, I was getting through it. So by the time I was 13, I could fix a car, but I didn't have a car and I didn't have any tools. But then by the time I got my license, I had been following racing on TV and then became interested in sports car racing. At that age, you could only do one car on the track at a time. But by the time I was 21, I had acquired a real race car and won the Midwest Council Championship between my freshman and sophomore year of med school. So that's one of my big med school accomplishments.
That's great. So how did you decide to go into infectious disease?
Well, it's again going back to that same time. In medical school, you don't know very much about various specialties. The only specialty I had ever interacted with was my pediatrician. And so as you rotate through the various specialties, you try to see what you like and where you fit. But I was impressed that with every rotation I went through, whenever there was a patient they couldn't figure out, they called one guy in Chicago, Dr. Stuart Levin. And they would call him up and say, "Stu, this is Lee Rosenblum. I've got this patient. They've got this, and this. What do you think we should do?" And so this one guy was figuring it all out. And I decided that's what I wanted to do. So I applied to Rush, where he was the head of the section, and ultimately was accepted there. And then I had a magical first month of internship, my first night of internship and my first month of internship, where I made a lot of diagnoses, including making a diagnosis that my mentor had missed.
Oh, wow.
It was tuberculosis in a kidney transplant patient. And so then he came to offer me my fellowship at the end of my first month of internship. So my future was cast then, and I went on to then do infectious disease at Rush and then went into practice.
And your skills have become useful because you helped one of your children recover from COVID, right?
Yes, I have one son who has recovered, and then another near family member who I had to treat, and I've treated a couple of other patients as well.
Yeah. So I believe when we were talking before, you said there was over 300 scholarly articles on this already?
Well, there's 3,000. Yes, there's articles being published every day, and they're coming so fast you can't follow them.
Yeah.
But there are literally now thousands of articles. One problem is many of them are in Chinese, so they don't have abstracts.
Yeah.
But they're coming right and left, and there's all kinds of research projects going on now. Maybe we'll talk about some of them as we move on in this discussion.
Yeah. Like I said, I'm thrilled to speak with you. So, what is the latest thinking about this virus? And I'm just going to let you wing it and go for it.
Well, I think it's important when we discuss this virus to begin the subject by saying there's much more that we don't know than we do know. And the advice that we give has been changing, sometimes very frequently. Within 24 hours, the CDC may change its mind. So with any contagious or infectious illness, we need to know how it spread. We need to know the mechanism by which it spread. And I'll come back to this. But we don't really know that as well as pretend to know it. And then we have to know how to treat it, and then we have to know how to prevent it. And we don't have solid information in either of those areas. We've begun to understand a few things about this virus that make it very clear none of us have ever seen anything remotely like this before. People compare it to influenza, the flu. It is not like any flu we've had in the past 100 years. It has one similarity to the influenza of 1918, the famed Spanish flu that killed 50 million people. Because in that year, influenza virus had a unique mutation. That virus has been recreated, so we understand it well now. It had a unique mutation that gave it specific binding sites in the lung. So people who got influenza that year got influenza pneumonia, which is a highly fatal disease. After that 1 year, we've never seen that in influenza before. When people get influenza now, it's only under very specific circumstances, the third trimester of pregnancy, or if you're immunocompromised. Pneumonia after influenza and death after influenza usually occurs from bacterial pneumonia that follows the viral pneumonia. This virus, we have learned, has a startling mutation that allows it to bind to a specific site in the respiratory and cardiac system called the ACE2, angiotensin converting enzyme 2 binding site. All of us in healthcare are familiar with the abbreviation ACE because we have all kinds of ACE inhibitors and ARB inhibitors that we use to treat hypertension. Lisinopril, for example, is an ACE inhibitor. It's one of the most commonly used antihypertensive drugs. Well, this bug has a mutation which makes it bind specifically to that receptor site in our cardiovascular system. Actually, not the specific one for lisinopril because that's ACE1. This binds to ACE2. But what that means is that everybody who contracts COVID gets pneumonia. And if you see the CAT scans, they're usually multilobar pneumonia, often they're bilateral pneumonia, and that leads to respiratory failure. And so the risk of death with this virus is much higher. Now, I don't want to sound like a complete paranoid lunatic because there are some bits of good news in here. First, while there have been a few reported deaths in pediatric patients, the kids are mostly spared of any significant disease. Death in the children is extremely rare. So that as we're working and we have young children or grandchildren at home and we're afraid we're going to give them something awful, they tend not to get anything awful. As we get older, the risk of having serious disease rises and the risk of death rises, and it rises rather suddenly after the age of 65. Then there's a jump at 70, and then there's a big jump at 80, where 80-year-olds have a mortality rate that's approaching 15%. So if we have a very high risk group, it's our advanced elderly. If we want to protect someone, we need to protect them. Now, one thing that I think has become an item of some interest and discussion is, how do we catch this virus? How does this virus spread? When we see a coughing illness, we tend to presume I get it by you're coughing up some sort of droplet or small particle and I breathe it in. And that's logical, and it may be the correct answer. But there are many people who feel that the bigger methodology of spread is contact. The virus can live for hours on a hard surface. And so touching that surface and then touching your face, your nose, your lips, can cause you to get the virus. Now, for those of us in healthcare, this has been studied. And when people medical professionals in lectures have been observed as to how many times they touch their face in an hour. And the average number is 23 times in an hour. That you'll rub your hand across your forehead or rub your hand across your chin. Your nose gets it about 5 times in the hour. And so if the surfaces are contaminated, then we can contaminate ourselves easily with touch. Now, one factor that then would raise a question is, why then are we so concerned about masks? Because of course there is aerosol. If someone coughs, we breathe it. And we recently saw a very interesting epidemic of how you can be hyper contagious One person in a choir gets it, and in the act of singing, that forced projection of singing infected half the people in the choir. So that respiratory droplet clearly was, highly contagious. I think that we wondered, is the mask appropriate for us? And am I discounting the value of the mask? No, I want to be very clear. I think that in this epidemic, wearing a mask is helpful in more than one way. And then there's a word of caution that goes with it. Wearing the mask is helpful because it may block the aerosols or some of the droplets that you might be inhaling and prevent you from getting it. I think that's pretty obvious. Wearing the mask is also effective because it stops you from touching your nose and your mouth. And so one of the big rules is don't touch your nose and mouth. Certainly you want to have washed your hands before you touch your nose or your mouth. And then don't touch the mask. Now, earlier on in this epidemic, there was official recommendations that healthcare workers should not routinely wear masks. Because when you wear a mask, it causes you to touch your face more. The mask needs to be adjusted. And so I would say the right lesson to take away in terms of self-protection and protecting the patient, and I'll say that again in a moment, is put the mask on and then make every effort not to touch it. If you're going to touch it, remember that if it's got anybody else's germs on it, you now have that on your fingers. So then you'll have to wash your fingers. You'll have to wash your hands. Or alcohol sanitizer works equally well. So let me emphasize this one more time. While there has been a difference of opinion on whether healthcare providers should wear masks when they're in a high-risk environment, to me, I think the answer is very clear. There are two things that drive us as healthcare providers. One, of course, is our wish to help the patient and protect the patient, and there the mask is beneficial in an obvious way. But the second is that we need to protect ourselves and our family, and there the mask is beneficial in a second way. So I would strongly recommend that routine mask wearing during this epidemic would be an important self-protective step, with the proviso of don't touch your face, don't touch your mask, and go on that way. Now, we haven't talked about the N95 mask, and when you need it, we might want to get to that later if that subject is of interest to you. Where would you like to go from here?
How can healthcare professionals protect their families when they come home?
That's a great question. So the mask is the first thing that we've defined. I think that if you have not been in an environment where, there is COVID-19, if you've not been on the unit of the hospital, right now, most of the hospitals that are taking care of these patients sequester them in units or segments of the hospital. If you're not in that segment, I don't think you're in the class where you have to take off every article of clothing, get in the shower before you can say hello to anyone in your family. I do think that when you come home, hand washing is important before, hugging your kids or doing much besides that. Now, the next thing is to use the knowledge in a way that will avoid transmission from ways we don't think about. Meaning, yesterday, I went to the supermarket to pick up a few things. And one of the things I picked up was 3 grapefruit. Now, I got home and recognized that I hadn't thought of one thing. Who else had touched that grapefruit before I had touched that grapefruit?
Right.
And so you recognize that for those things that have human touch, you have to, again, be very conscious about washing and hand washing. So I think that is part 2. Part 3 is to be very cognizant of the symptoms. Remember, even though we're self-isolating at home and you as a healthcare worker may be going to the office or going to the hospital and coming home, self-isolation also causes us to go to that supermarket. where we're standing in line behind 6 people, you know, who we don't know at all, and we're obviously rebreathing their air. And we're just a couple of feet from the person at the cash register, and now they've put these plastic screens in between. But that person has already dealt with 400 people, and they're handing us the receipt. Well, remember, the virus can live on paper for hours. So we have to be cautious about that sort of interaction. Would putting on disposable gloves or any gloves at all be helpful in that regard? Yeah, it might. By the way, I read one more interesting, I have not seen anyone do this yet, but I read one more interesting recommendation on the avoid touching your face, which is wear gloves that are sort of rough on the outside surface. And so you tend not to want to put those on your face and go that way. Now, one more thing that I would point out is that because of those exposures where someone's going to the supermarket or someone else is doing something, everyone can get exposed. So be alert for the early signs and symptoms of this infection. Remember that this infection is different from almost any other that we deal with because of the very prolonged interval between the time you're exposed and the time you get sick. That latent incubation period is often 7 days. And in those 7 days, people are contagious. And those are the spreaders. You come across someone who seems perfectly healthy. They were exposed to someone who had the disease. They didn't know it. Now they've met you, and now you get it. So we want to be alert to the symptoms so that we can seek evaluation, testing, and possibly treatment. And we'll come to treatment in a short while. And say, so what are the symptoms of this disease? Well, the initiation with cough is common. And interestingly, the cough is not the violent, deep cough that you are familiar with pneumonia or even influenza. The cough is the little bitty cough that you see with mild colds, the cough. You're not coughing up globs of phlegm. So the first thing you may find is this mild cough that doesn't bother you a bit. Then fever may occur, and fever with that cough is the real important clue. There are other symptoms which can include sneezing and sniffles. Muscle aches are quite common. But then there are also surprising other constitutional symptoms. Unlike other respiratory viruses, diarrhea often is a presenting symptom. But along with that gastrointestinal symptom, there can be others that are not as easily identifiable. Loss of appetite is actually reported among people who present with this disease.
I heard about the smell too.
Loss of smell as well.
Yeah.
And those the Chinese characterized as gastrointestinal symptoms, but it's important to recognize those because when you recognize those, that's when you want to get yourself high up in the line for testing, because we'll come to treatment, you know, in a short while after that. Did I answer your question a little bit?
Yeah, I have a couple other questions though. So nurses who are taking care of people that are on other units, you said they don't have to be as concerned, but if these people could be carriers or, you know, pre-sick, as you say, within that 7 days, shouldn't they still wear a mask and take precautions? Yes.
I think that whenever you think there's a chance of exposure, let's say that if Lorie, you're working as the nurse and your husband comes home and says, you won't believe this, but George in the office was just found to have COVID. Now your husband knows George and your husband is close to you. So now you say, oh my God, what do you as a healthcare worker do? Ideally, you would report it to your superior so they know what's going on. And you would monitor temperature for the next 7 days. And then religiously and without fail, you would wear a mask for the next 14 days. You know, from the time that you recognize your possible exposure, you'd wear a mask for 14 days. And that, I think, would be adequate protection for others around you, and it certainly alerts you as to what you need to be watching out for. Did that answer your question?
Yeah, but I'm thinking about the patient may have been exposed and not know it.
Say it again. What's it?
Like a patient on a non-COVID unit may have been exposed and not know it, and may be contagious. And then if the nurse takes care of them, she could easily spread it to the entire unit.
Well, that is obviously the scenario that occurred in the skilled nursing facilities.
Mm-hmm.
And so that's why we would say wear a mask for every one of those contacts. Now, for those contacts which create the most highly contagious aerosols, and that would be breathing treatments, like nebulizer treatments, there, if I was the nurse taking care of that patient, I'd want an N95 mask, I'd want a gown and gloves to do that. And then you make sure the door of the room is closed for the next 2 or 3 hours, so all those little droplets settle out and they're not in the air for the next person who walks in.
And when other times are N95 masks indicated?
When are N95 masks indicated otherwise?
Yeah.
I'll talk about the specific indication, and then I'll talk about what I think is the broader indication.
Okay.
Remember, people are concerned that we're going to overuse N95 masks and there aren't enough N95 masks. But I'll point out that we've become very flexible in how we use them. If you go back a few years, an N95 mask was used one time for one patient. If you needed another saw another patient, you put on another N95 mask. Then came recommendations, oh no, you can wear them for 5 patients. Then more recently, there was an observation that some of the N95 masks we have expired. And then official releases have indicated you can ignore the expiration date, you can still use it. Well, now you can use it for more than one patient, you can use it for more than one day, and you can use it in a variety of circumstances. So yes, whenever there's a known risk of COVID or an aerosolized procedure, then an aerosolizing event, I would go with the N95 mask. But if you're in a high traffic zone, if you're the person in the ER who's evaluating patient after patient, and you don't know the COVID status of any of these patients, I would say N95 mask for you all the time. Mm-hmm. Now, if you have an underlying condition which puts you at higher risk, and let's talk about that for a minute. We as healthcare providers would think of conditions that put us at higher risk as chemotherapy or immune suppression for autoimmune disease. You're on treatment for Crohn's disease and with Humira, and that's an immunosuppressive. So yes, you would wear an N95 mask because you can't stand, you will not tolerate the smallest risk of exposure. But what other underlying conditions would cause someone to say, I should be concerned about me and protecting me in a situation where I don't know who I'm coming across? Well, cardiovascular disease has been identified as a major risk factor in the people who don't do well in the ICUs. So if you have significant hypertension, you're on antihypertensive medications, I might put myself in that higher risk group. But let me be candid. I'm on antihypertensive medications. When I'm in the healthcare environment, I wear an N95 mask. Here's another one that is now only gaining recognition. Obesity has been another major risk factor for those who do badly with this disease and pneumonia. So if that is a condition that you suffer, that you bear, then I would say that was another condition which would cause me to say, wear the N95 mask. Now, you can wear it one day, you can wear it the next day. There have now been guidelines for how you store your mask overnight. I don't know if you've seen the recommendation that you get a gift bag that has the little handles, and then you put it in the bag with the earpiece hanging over the handle so that anything that hopefully the all paper environment will cause the organisms to be dead before the next time you put on the mask. So I think I would go that route. Did that respond to your question?
Yeah, I mean, do you think it's safe to reuse these masks?
Yes, I think first, what's available and what is possible supersedes what's ideal.
Yeah. Okay.
Yes, if you had an unlimited number of masks, you could do that, but you're not going to have an unlimited number of masks today. So you use them as long as they appear to be intact and as long as they appear to be clean. People are starting to develop ways with ultraviolet to try to sterilize their masks, and then periodically you may need to change. You know, if you wonder, yes, you know, I have a team of 4 nurse practitioners, and all of them have several masks and face shields. And when they seem to be not functional, you know, not reasonable anymore, we'll have to provide new ones.
Okay. And then let's talk then about, oh, you said we haven't seen anything like this. It's a derivative of SARS though, but how does it differ?
Well, SARS and MERS, the Middle Eastern respiratory virus, and this COVID-19 are all coronaviruses. And coronaviruses are also common cold viruses. In that rapid respiratory panel that we do that checks influenza and respiratory syncytial virus, it also checks for several coronaviruses, but not this one. They have all mutated to have a higher mortality than the cold viruses, in part because of their specific ability to bind to other sites in the body. But what differs with coronavirus is its infectivity and the prolonged latent period, where people can just spread, and no one knows they've got it. And so one person on an airplane can give it to 10 people on the airplane. Those 10 people get on other airplanes, and suddenly you quickly have 1,000 people who have coronavirus. We didn't see the same thing with SARS and with MERS. There's one more thing that may or may not be true, but it concerns me. And I'll say it, understand, I don't want to create a sense of paranoia, but there is an observation that I think should be noted. This began in China, and China reported a lot of cases and a significant number of deaths. We in the US have now surpassed the number of deaths that the Chinese have admitted to. We don't know how accurate their numbers are. But recognize that Japan got through this with almost no problem. Hong Kong, again, South Korea, very minimal in the way of problems. But when the virus got to Italy, it instantly infected tens of thousands of people with thousands and thousands and thousands of deaths. And so it raises the question of, is this virus attachment to those ACE2 sites more active for Caucasians than it is for Asians? And this may then be a disease which is Europe and North America more than other places.
Interesting. And so let's move on to treatment.
Well, treatment is the most important thing. And the question is, what are the drugs and when do you give it? And are there other factors in this disease that alter your thinking? So from the very first cases, the Chinese reported that they were using a combination of HIV drugs that are sold in this country as Kaletra and Plaquenil. And Plaquenil had also been used in the SARS-MERS era. So Kaletra exists here, but it has been used in some patients, but it has not been used with the results have not been extremely promising. And it's been associated with a rise in liver function tests, which have caused people to become reluctant to use it. To me, the most interesting article about Plaquenil did come from the Chinese literature. And it showed that when Plaquenil was administered in fairly moderate doses, meaning 2 pills twice a day for 1 day, and then 1 pill twice a day for 5 days, with azithromycin in the normal Z-Pack fashion, 2 pills and then 1 pill a day. The viral counts in the patients diminished very rapidly, and by the end of 5 days, the people who got treatment had much less virus detectable than those who did not get treatment. And so Plaquenil, in terms of its effect on the virus, appears to be a positive. And so I would strongly recommend that. Now, with our misunderstanding of this disease, some people have defined protocols for using Plaquenil. And as an aside, the FDA has not licensed Plaquenil for this use, but has currently approved it. They've approved the use, which is different than a form of licensure. People have said, well, you know, it's a drug in short supply. We should use it for the sicker people. We should wait until their disease is fairly far advanced and then administer the drug. So we want them, if the lowest acceptable O2 saturation is 92%, we won't give it to anyone unless they're below 93%. So that gives Plaquenil to people who are already far advanced. But what we're not recognizing is that the end of the disease is a little different than the beginning. The beginning of the disease is the bug multiplying, the virus multiplying and attacking lung tissue. The end of the disease is an immunologic, cytokine attack on lung tissue, where the host's response becomes the enemy of the host. All those chemicals that we make, interleukin-6, et cetera, are accumulating and attracting white cells and clogging up all the passageways and ultimately resulting in respiratory failure. We may be better off lowering the viral loads before we get to the cytokine overload. By the time someone is getting respiratory insufficiency, they probably already have the cytokine syndrome, and the antiviral may not be as effective as suppressing the cytokine response. So now there are people who are beginning to use it on the less ill patient. And as healthcare providers, my advice to all of you would be that if you get the disease and you get tested, you're waiting for that result to come back. And in those days between the time you get tested, if you're magically well, which happens to most people, then you don't need to be treated. If in those days you feel you're getting worse, I would be insistent on treatment. Treatment is fairly benign. Yes, it can prolong the QT interval. Your doctor might want an EKG to make sure your QT interval is normal. Azithromycin is benign. And so if you are worsening in between the days your test is taken and you got the result back, then I would be strongly in favor of treating you before you become hypoxic. Now, there are drugs which are being used in trials to fight the cytokine response. A drug that people are calling TOSI, which is tocilizumab. It's another rheumatology drug that fights IL-6, is being used to suppress the response, and the early results appear to be favorable. When you look at the blood tests of people who are going into the serious stages of lung failure, the inflammatory marker elevations are quite remarkable. We're all used to sed rate and CRP, but if you look at a bad infection, an infected artificial knee, you might see a CRP of 80. That would be very high. Normal is less than 2. In these patients with their cytokine response, they're seeing CRPs that are well over 300. So the body's immune system is just switched on. They can measure IL-6, but it takes about 6 days to get a level back, and those levels are also markedly elevated. Serum ferritin is remarkably elevated. So the body's immune system becomes its enemy in that stage of the disease, and we have to be using treatments to suppress that. In the past, all we've had is prednisone, and that may not be the right answer because it also allows the virus, to perhaps grow farther. So maybe the right answer is going to be antiviral medications plus anti-cytokine treatment, and hopefully we'll see some improvements as our knowledge base increases.
Okay, great. Wow, such wonderful information. Thank you.
Well, thank you for asking. The big hope, well, first, let me be a little bit of a pessimist for a second before I'm back to being an optimist. We're all on our social isolation regimens now, which I believe will work, and I do believe that they'll probably be released at the end of the month. But I would say we have to be ready for a second wave, because even at the end of the month, only a small fraction of our population will have been exposed and immune. We'll be doing more testing so we can identify people earlier. One thing that we haven't done is track down all the contacts of those who are COVID positive so they can be isolated very carefully. China did that. We are not doing that, and that may be coming as well. So I do think there will be a second wave, and the second wave I don't think will be as bad as the first wave, but I don't think we're going to be through with this until we get a vaccine. Now, people are already working on the vaccine. You know, if things really get accelerated, hopefully it can get approved within a year, and maybe by 18 months we'll be distributing a vaccine so that we can prevent this from happening to us again. The other thing that will increase very dramatically is testing. You know, we were initially testing 3,000 patients a week, and now we're testing 50,000 patients a week. But we need to be testing hundreds of thousands of patients. We need to be testing almost everyone to figure out who's had the disease, so they're immune, and who may get the disease. I think that in an ideal sense, if you're working in a hospital today, you'd like every one of your patients to have a COVID test on entry. You got a CBC, you got a complete metabolic panel. How about a COVID-19 test to make sure that this patient is safe for me to take care of? And of course, you'd like to screen the healthcare workers. You'd like to know that you haven't got it and that you don't need treatment. So I think that the significant increases in screening will go on as well. And that's a vital part that we've missed so far.
Yeah, they do that, or they used to do it for MRSA too.
I didn't hear that. Say it again.
They used to do that for MRSA, screen on admission.
Yeah, they still do. I mean, you can't get knee replacement without having your nose swabbed. So that I think would be a very important part of long-term control. We'll hopefully make more progress in that direction. There's one more thing that I think we should be investigating, and I think has a ray of hope in it. We've talked about Plaquenil, hydroxychloroquine, as treatment. We haven't talked about it for prophylaxis. The studies should be done where X number of people have been exposed to someone who now is found to be positive. We take half of them and put them on low-dose Plaquenil for a week, and half of them we observe. If the half on low-dose Plaquenil don't get the disease, then we have a way to prevent the disease. If you know you're going to a rock music concert in an auditorium that holds 20,000 people, maybe your ticket should come with a Plaquenil pill. So you can take that before you walk in. But I think that prophylaxis will be something that we'll investigate. We should have an answer on it. And I'm a bit optimistic on it. I think that this medication may turn out to be an effective prophylactic medication.
You said that people can be, once they have COVID, they can be immune to it? There's no reinfections?
Say it again. I'm sorry, I didn't hear.
If people are immune, you can, if they've had COVID, they become immune. Is that what you're saying? They can't be reinfected?
Well, I think it's a mistake to pretend we know more than we do. We don't know how permanent the immune response to COVID is. And remember, the coronaviruses have more RNA than any other viruses. So they have tons of places for mutation. It's possible that we'll make a vaccine that works against some of the antigens of coronavirus, and then suddenly it mutates, and now we have another strain, and it doesn't work as well. So we're in a learning process and we just don't know. There are people now who are looking at harvesting the gamma globulins from people who have recovered from COVID-19 and giving that concentrated gamma globulin to patients who are suffering from COVID-19. And that may turn out to be another effective treatment, one more in the arsenal. I think it's going to be hard to collect that much blood, but it may be something that can be used from time to time.
Interesting. Well, I so thank you for taking your time and being our guest and sharing your knowledge, because, you know, it's scary and there's just, you know, there's so much conflicting information out there. So I truly appreciate it.
Well, I'm delighted. I would simply say that tomorrow I could be proven wrong on everything that I've said, and I'll simply come back and apologize for that. I have taken a position on things that I think are likely to work out, such as treatment, but clinical trials could prove me wrong. But we're a nation that has a lot of resources we can dedicate to this. We have a lot of resources that can be used for manufacture. And I think that we will come through this, although the period of suffering will be significant until we get through this. But I do think there's light at the end of this tunnel.
Thank you. That's good to hear. And for all of you on the first line out there, you know, we thank you. We really appreciate you and bringing you the information that I can, that I know to get, and we're praying for you. So thank you, Dr. Stemmer. Appreciate
Thank you.
it.
My pleasure.
Thanks for listening, everybody. Bye.